I am Stephanie Yolgenfritz. I am the Health and Science Editor at the Wall Street Journal, and I'm here with Dr. Jay Bhattacharya, who is the Director of the National Institutes of Health. So thank you for coming and joining us here today. I wanted to start with a pretty basic question, I guess. You're a trained physician, but you really have been an economist, a healthcare economist, studying healthcare economics and population health. And I wonder why, as an economist, did you want to be the head of the NIH? Why trade the dismal science for life sciences, where you hang out with people who experiment with mice?
Well, I mean, what a question. So I always wanted to be a doctor. I discovered economics as an undergrad, did some research, encountered a man named Alan Garber, who's now the president of Harvard, was my mentor. And he has an MD and a PhD in economics. And I decided, it turns out the tools of economics, where almost never you can run randomized trials, have a lot of application to medicine. That's basically how I made my career. I never set out to be NIH director. I always thought I'd be a professor. I was a professor for 25 years. But it turns out that the tools of economics are really, really important and useful in thinking about science policy. It's something I've studied and researched in my career. A lot of the questions involve, trade-offs. A lot of the questions involve understanding how investments pay off over a long period of time. Incentives, behavior, those are all really crucial to science policy, turns out.
All right, well, I want to talk about something that you have said is one of the reasons you are the director of the NIH today, going back to the pandemic. And I don't want to spend a lot of time on relitigating the past, but I do have something I want to ask you about it. You are, if there's anyone who's been living under a rock, you were the co-author of the Great Barrington Declaration, which was a statement in the fall of 2020 that called for the end of lockdowns, the end of masking, and for the greater part of society to return to school, to return to work and normal activities, saving the elderly and the sick, with the idea that we should have natural infection and get to herd immunity faster, and that would be a better way. And I think that looking back, many people believe that it's clear that those lockdowns were harmful for children, for education, and for mental health. But I also, myself covering the pandemic at the time, casting my mind back, I remember the fear at that time. I remember the concerns that young people, young healthy people, were dying. People who were 40, 50 years old get blood clots and stroke and would die, and the doctors and nurses caring for people would die. And the public health officials at the time expressed concern that opening up and possibly people would die and that it would overwhelm the healthcare system. So my question is this: do those arguments at the time have no merit at all?
Yeah, they had no merit at all. If you look at what happened during the pandemic, you can look at what happened in Sweden, right? Sweden never closed schools for anyone under 16, never. And the Swedish experience was instructive, even by then. The Swedes have the lowest all-cause excess deaths, meaning take all deaths, get expectations about how many people normally die in non-pandemic years. Excess means how many above that what happened, right? The Swedes have the lowest all-cause excess deaths in all of Europe, and they didn't lock down in that same way. And I'm sorry, just one more second on this. The evidence for the harms of the lockdown were very, very clear by October of 2020. In April of 2020, the UN issued a report that almost 130 million people would starve as a consequence of the economic dislocations caused by lockdowns worldwide. Parts of that came to pass. Huge numbers of poor, working class people and children were harmed already by April of 20. There was a report in JAMA JAMA Pediatrics in the summer of 2020 that the spring shutdown of schools had already cost American school children 5.5 million life years in expectation. Yeah, the evidence was really clear that the lockdowns had failed to protect anybody from getting COVID and were causing tremendous collateral harm.
So I have to ask you a follow-up question. When one of the complaints and accusations about the public health officials at the time was that they had no humility, that they were absolute in what they said, and that didn't foster trust. Do you have any humility about your position?
Well, can I ask you this? Where were you when the head of the NIH declared that me, Martin Kulldorff, a professor at Harvard, and the Sunetra Gupta, professor at Oxford, were fringe epidemiologists, and asked for a devastating takedown. That led to death threats against me. That led to hit pieces about me, essentially propaganda, arguing that I wanted to let the virus rip, when in fact I was reflecting what the scientific evidence of the time was saying.
All right. Well, I don't think that the question was quite about the personal issues, but let's move on. Because I said we've litigated this quite
Stephanie,
a bit.
If you're going to go down this route, we should go down this route.
So then, all right. Would no one have? Then let's. All right. Let's go.
Honestly,
so on the epidemiological question, would no one have died? Would no one have died? Excess deaths? Would there have been no excess deaths?
I mean, look at what happened in Sweden. They have almost zero all-cause excess deaths through the whole pandemic. I mean, the question is, was there a lot of uncertainty at the time? Yes. I mean, if you write something and say, look, we should choose a different policy than what many other people are saying, what you're calling for is a debate, a discussion. Instead, what we got was devastating takedowns. And as a result, American school kids are 2 years behind in schooling or more. We damaged our society on the false premise that we're protecting people from COVID, older people from COVID. We failed at that.
You have called Francis Collins a failed leader. Have you spoken with him since you've been NIH director?
I have.
What did he say?
We forgave each other.
Okay. All right, so that's the past. Let's talk about the future and your vision for the NIH. You have laid out a number of pillars. Reproducibility in science is one of your agendas, addressing chronic disease, and then fostering more innovation in edgy science. So I wanted to start with the reproducibility issue. I think there's broad agreement for years now in the scientific community that there is a reproducibility, often called a crisis in science, that the science can't be often replicated, that there are retractions that come too late after people have already built on that work that later turns out to be flawed. So stipulating that there is a reproducibility crisis, what will you do to change that?
Yeah, so first, a quick second about the reproducibility crisis. The issue is deeper than people appreciate, right? So drug developers tell me that they can't trust the published biomedical literature because much of it, when independent teams actually go back and try to find the same result, they don't. There have been studies actually funded by the NIH to find up to 70% of the published biomedical literature doesn't reproduce. And the reason is very simple. It's because science is hard. A lot of this, and the incentives in science are to publish papers with statistical criteria for deciding whether they're true. Really, it's an epistemic problem. What we think of as truth is it published in a top scientific journal, and that by itself determines whether it's true or false. But in fact, that's not what determines truth in science. What determines truth in science is other scientists looking at the same thing. Do they find the same thing? And that's why the reproducibility crisis, the solution to it is replication. Creating a culture in science where replication, where you look at results and say, are other people independently finding the same thing as the original claim? And make it so that if a scientist is subject to replication, it's an honorable thing. It's a good thing rather than a threat. We have to change the culture of science that says truth is determined essentially is by a community of scientists checking each other's work, rather than by authority, which is you got published in a top peer-reviewed journal, and therefore what you said is true.
And because so much research builds on prior research, if you can knock out the things that cannot be replicated sooner, arguably that would have a long tail in science. So I wonder though, how will you prioritize what needs to be replicated? I don't know that you want to go back and relitigate every single piece of science that was ever produced. And there are concerns that relitigating established science would be a waste of money. So I wonder, and also that relitigating established science, hoping for a different answer that is predetermined at the outset, is also a concern. So how will you prioritize what needs to be replicated and avoid, possibly agenda-driven?
That's a great question. So I think the key thing is you have to let the scientific community determine what the key questions are to be subject to replication, right? So the rate-limiting step in science is some idea, and some scientific field, some idea. Let the scientific community tell us what that idea is, and then replicate that. Have folks replicate that. The key thing is, from the NIH's perspective, what we can do is we can put out grants and say, look, what are the key ideas in your field that need to be replicated? What are some creative ways to do the replication at scale? How can and then provide a place where people can publish their replication efforts. It's difficult to get papers published in if you're just replication. You can't get a paper in New England Journal of Medicine as a pure replication. I talked to the head of the AAAS, the American Academy of Sciences, who runs Science Magazine, and he told me that there was no way he was going to publish replication.
It just copies what was already
yeah, it's just copies what was done. But in fact,
it's
new knowledge. Like the fact that some idea has been replicated is actually new. It's absolutely essential. What was the second question you asked? Sorry.
How will you avoid agenda-driven decisions that would set a predetermined outcome and then try to find research that comes up with that different answer?
Yeah, I mean, the key thing is to do honest science. If you have independent teams asking questions from different points of view, and they all find the same thing, then you have more confidence that the thing is right. If people are, if people of different points of view find different things, then we're basically in the situation we're currently in. What we need is a culture of science that lifts up science that is replicated, science that where independent folks find the same answer. Everybody has an agenda. The issue is not that. The issue is, does the scientific method of different approaches to the same problem produce the same answer?
So the other thing that you want to prioritize is chronic disease. And when I think about the position of chronic disease right now in America, that over generations, longevity has increased significantly. It's flattened a bit, for a lot of reasons in recent years, but what kills us has changed, right? In the past, we died of infectious disease, we died of influenza, and we died of tuberculosis, and now we die of cancer and non-communicable diseases, heart disease, diabetes. And I think that there is broad agreement. I don't think there's anybody in this room who would disagree that chronic disease is something we need to spend more resources on, because that is what's killing us. But infectious disease is still with us. So my question is, what does this mean for infectious disease? And your boss, HHS Secretary Kennedy, has said in the past, and this was when he was running for president, we're going to give infectious disease a break for about 8 years. So is that the plan, or do you tend to support a balance?
I mean, I think that there are a lot of threats to human health. Since 2012, there's been no increase in life expectancy in this country. Right, from 2012 to 2019, flat life expectancy. I mean, that's a scandal if you think about it, right? Given the money that we've invested in research and science, but also the huge amount of money that we pay for care for people with heart disease, with cancer, with diabetes, with obesity, of course, and a huge range of other chronic diseases. There's a real need to address those things. A real need, and this is in light, and even though there have been tremendous advances in science during that period, huge advances in genetic technologies, and as you say, of course, infectious diseases remain a problem, right? Those have not gone away. HIV is still an epidemic with us, right? This is the 45th year or something of that epidemic. So we have to do things about all of these things. The fact that we've had no life expectancy increase means that the advances that we have had in science have not translated over to the most important things that actually impact human health in this country, and we have to fix that problem, right? People fund the NIH through their taxpayer dollars in order because the mission of the NIH is such a noble thing, right? The mission is that we should invest in research that advances the health and longevity of the American people. And of course, those advances don't just help the American people, they help the whole world.
Does that mean you will include infectious disease as part of the portfolio of research that the NIH
I mean, it's a tremendously important part of the portfolio, and of course it will continue to be.
Okay. And so another pillar of your goals for the NIH is innovation in science, fostering edgier science. And you have said that science is too risk-averse and that we're punishing failure too frequently. So how will you fix that?
Yeah, so just to back that up, I did a paper before the pandemic published in 2020 where I asked how new are the ideas in NIH-funded research and how has that changed over time? So first, how do you ask that question? Well, what you do is you can create like an automated history of science, of biomedical science, by looking at all the papers published in 1940, all of the papers published in 1941, taking all the words in the papers in 1940 and subtracting off the words from 41 and subtracting off the 1940 words, which are left with all the new ideas that were introduced in medicine in 1941. You do the same in 42, 43, 44, 45, you get a history of biomedicine. you go back to the papers and ask, what's the age of the newest ideas in each and every paper? And then what you find when you go back and ask, how old were the ideas in the newest paper, in the papers published by NIH-funded research in the 1980s? Well, in the 1980s, NIH-funded researchers were publishing papers with ideas that were 1, 2, or 3 years old. By the 2010s, the NIH-funded researchers were publishing ideas that were papers that had ideas that were roughly 7 or 8 years old. So we've become much more conservative, much more afraid of failure in science than we had been in the past.
So how will you fix that?
One is we have to give support for early career investigators. We failed at that. We absolutely failed at that.
I think that's playing well to the audience.
Yeah. Okay, this is a really depressing thing for me personally with white hair. I published a paper with the most depressing result I've ever had. It turns out that the time in your life when you're most likely to try out new ideas in your papers, in published papers, is year 0 after your PhD. And then it's monotonically declines. It's the sad, long decline to me. I'm like now 30 years, oh my God, 30 years into my career. And it's sad. I'm like, you know, I'm on the twilight end of my, and I'm working, and for every year of chronological age, scientists tend to work on ideas that are about 1 year older. 1 for 1. So having support for early career investigators is going to be a really important part of that. Right now, the age at which we award scientists their first large grant, the median age is 45. It used to be in the 1980s, it was in the 30s. And we ask young researchers to do postdoc 1, postdoc 2, postdoc 3 before they have any chance of going into assistant professor, trying their ideas out. We have to fix that. Now, I know the NIH has tried to fix that in the past, and partly it's the way, I mean, there's lots of reasons that we could get into, but I think that's going to be a very important part of them. Science really advances when we allow new ideas to refresh how we think about things.
Well, one thing you've said about trying to encourage edge science, as I think you've called it, is to foster more openness in conversation around ideas that may be outside of the mainstream. So how will you foster that kind of open dialogue?
Well, this is one of my major aims is we have to, in fact, this was probably the biggest problem during the pandemic, to my mind. You talked about humility earlier. The problem was the scientific community was not humble, fundamentally not humble. They decided that they knew what was best, and they were going to suppress all the people that disagreed, you know, devastating takedowns and the like. The key to solving that problem is free speech in science, allowing people, even with ideas that I disagree with, to talk and talk to each other. If we allow that, you know, if you go back through the history of science, all of the most important heroes we have in science were on the edge, were fringe, we're talking about things and thinking things that were not actually accepted by the you know, Galileo, Semmelweis. You go back through scientific history, it's always people that were saying, that challenging the center. And so I think that the key thing is to re-embrace a culture of respectful discussion with each other, even when you disagree fundamentally with the premises of the people you're talking with.
So I have to ask if that freedom of speech extends to people in the mainstream who may disagree with these ideas that are alternative. And I'll tell you why I'm asking it this way, because one of the areas that the NIH has spent a fair amount of time in nutrition is looking at ultra-processed food. And the lead researcher there, Kevin Hall, retired recently. And he said it was because he felt censored by the agency. He was frustrated because some of he was told not to talk about his findings because they might contradict what Secretary Kennedy's positions are. So does free speech extend to all?
Yeah, it does. I mean, I actually spoke with Kevin Hall. I've invited him to unretire. If he can have whatever results he'd like. One of the first things I did as director of the NIH is I put forward a policy. What I found was that there was actually a culture in some parts of the NIH where if you're a researcher and you had a paper, you had to show it to your supervisor, and the supervisor would say, "Oh, well, I don't think this is going to play well. You're not allowed to send this out." I've had researchers within the NIH, when I was outside, come and tell me that it happened to them. I put out a policy that says that kind of substance review no longer needs to happen for intramural NIH researchers, that they can publish their papers. I fully expect there'll be papers that NIH researchers publish that I disagree with, and that is absolutely fine. That's how we learn from each other, is through that kind of disagreement. So yeah, I'm absolutely committed to that.
Okay, so let's talk about the cuts. There have been cuts, there have been freezes. to research at the NIH and at other agencies, and universities and researchers don't like any of them. They're expressing serious concerns about the impact not only in the near term on the research that they're doing and their ability to hire postdocs and continue their labs, but in the long term, America's prime position in innovation globally. One of the areas that I think universities are particularly concerned about is the proposed caps on indirect costs, which I think most people know it pays for like the labs, and it keeps the lights on, it keeps the centrifuges in good working order, and there's a percentage above the amount of the grant that is spent on this. And there have been these cuts that have been imposed. And one person who has spoken out against this is Harvard University President Alan Garber, who you've mentioned. I know you're close with him. You've called him basically a mentor. And he has written that with these cuts to direct costs, the discovery of new treatment would slow, opportunities to train the next generation of scientific leaders would shrink, and our nation's science and engineering prowess would be severely compromised. And so my question is this: if Dr. Garber were here today, and I actually don't know that he's not, but
hi, Alan.
what would you say to him?
Okay, so first, I can't comment specifically on the 15% thing is subject to litigation. So let's just put that to one side.
Understood.
Let me talk about the economics of indirect costs. So first of all, there's a collaboration, a partnership, if you will, between the NIH and universities. Right? A lot of, 80+% of the NIH budget goes to universities, and the universities of the country are our partners in conducting the scientific research. And it's about $48 billion budget for the NIH this year. $8 billion of it is, roughly speaking, goes to indirect costs. And as you said correctly, that money goes in general to supporting, supporting a square foot of lab space, making sure that there's light bulbs on, there's radioactive disposal facilities for chemicals to buy, all kinds of fixed costs of doing research. The economics of the way that we hand out that money are that you have to win a scientific grant in order to get the fixed cost support. Right? You have to have excellent researchers who win the scientific grants in order to get the fixed cost support. But if you think about it, it's kind of a vicious cycle. In order to have the excellent researchers in the first place, you have to have excellent institutions. It's a cycle that almost guarantees that places like Harvard, where Alan is, will almost always get the bulk of the fixed cost support that we give. But I've met great scientists across the country. I've met, and across the country, people tell me that it's very difficult if you're not in the top 20 universities to get NIH support. Why? Because they don't have the institutional support that would allow them to attract excellent scientists more, and then build a competitive portfolio where it attracts NIH reviewers to say we should give the money to them.
So you spread the money around a little more?
Well, the key thing is to break this cycle, right? We can't have the fixed cost support tied so directly to the direct costs. The right way to do this is to have sort of a competition across the country so that for that $8 billion. Right? So they can compete on cost. If Harvard or Stanford or whatever can provide a justification why the more expensive space they have is worthwhile, whereas University of Kansas can do it much more cheaply and probably just as well, why not give it to the University of Kansas instead of tying it so directly? The system as we have it guarantees that the rich will get richer and stay rich.
So that sounds like a sort of more equitable way of dispersing the money.
Yeah, absolutely.
Is that what you would say to Dr. Garber?
Yeah, that's what I'd say to Dr. Garber.
All right. So the actual number of cuts has been...
I should say one other thing.
Okay.
There's a scientific reason for this too, right? There's groupthink when you have such concentrated sets of scientists in just a few places. You have, by having more geographic dispersion in support for research, you combat scientific groupthink just simply because people are in different places and they're influenced by different things. Having almost all of the nation's scientists, essentially in 20 institutions that we support, that's not healthy for the scientific fields. Again, free speech, I think, is a really important part of this, but also the capacity to meet with people that are different than you.
Well, it kind of leads a little bit to my next question. estimates for the amount that's been cut or frozen, they're all over the place. One study in JAMA pegged it at $1.8 billion. The Grant Watch people, which is this research effort at Harvard, puts it at $3.2 billion. But I don't think we need to debate the numbers. We can go on and on about that. But a lot of it was clearly tied to DEI, that there was an effort to scrape all of the grant proposals for keywords that related to DEI and freeze those grants. But there's still, I think, probably broad agreement that there are actual differences in the races and genders medically. Black people get sickle cell more often, women get breast cancer more often. So, and you have said that you are going to implement an appeals process. And my question is, will you consider in that appeals process reinstating some of the DEI cuts?
Okay, so first, the commitment for the NIH to researching the health priorities for minority populations is unabated. Like the mission of the NIH is to promote research that advances the health and longevity of the American people, and that includes all of the American people, no matter what your race, color, a belief system, or whatever. So just I want to start with that because I think people mischaracterize this. If you look at I've now spent a lot of time looking at the NIH portfolio over the last few months. There's sort of like in the bucket of DEI, there's kind of two sets of things, and I want to distinguish them. One, I think, is really worthwhile and worth doing. Research, not to pick anybody in particular, I'll do a hypothetical example. Right? Suppose that I get a research proposal that says, I want to study how redlining impacts the health outcomes for black men and their screening for prostate cancer, right? Now you can think of a mechanism why that would be. Like if you live in a place where there's fewer doctors and it's more difficult to get to a doctor, you're going to less likely to have that kind of screening going on. It's a research question that's concrete. You can think of data that would test it, and it has some actionable things potentially that comes out of it. You can in principle falsify it. Either maybe it does or doesn't. The data would tell you one way or the other. That is the kind of research the NIH will continue to support. It's concrete, actionable, actually has a chance of improving the health of minority populations or anyone. On the other hand, let me contrast with a hypothetical research program that says structural racism is why minorities have worse health. Well, that is not actionable in the same way. I'm not even sure if you could find a data point that in principle could falsify it. It's not even science in the standard sense, and it doesn't lead to advances in the health and well-being of minority populations. It's just pure ideology. In a sense, what's happened is that the NIH had gotten into involved in the activity of trying to achieve some kind of cosmic social justice, to right historical wrongs, rather than its mission, which is to advance the health and longevity of the American people. That's hard enough. And so a lot of the grants we're talking about, we've been working with researchers to try to sort of remove out the second part and bring in the first part. We have an appeals process where that's taking place. It's slow and painful because for a long time the NIH absolutely did focus and did support research of that second kind. I think it's divisive. Large parts of the American people view it as political, purely political. It undermines confidence in science and doesn't actually result in improved health. Despite tremendous amounts of money poured into research on diversity, we still have seen very little difference and improvement in the difference between African American populations, their health, and white populations. Why is that? It's because if we're just focused on ideology and not on verifiable science that translates into improved health for people, we're going to end up in a situation where people don't trust science. People think it's a political thing. People, especially after what happened during the pandemic, I can understand why. I mean, people lost their jobs over vaccine mandates that made absolutely no sense. That people started to see science as a fundamentally political activity to rule over them, rather than as something that's just an amazing engine for discovering truths that help our lives, which is really what it should be.
So one more question about the grants. Some grantees have not been told why their grants were cut or frozen. And the NIH actually did instruct staffers to specifically not communicate with universities, Northwestern and others, about whether or why their grants were frozen. So how does that fit in with your goals of transparency?
So there's litigation over, there's a whole range of actions taken by the administration with Harvard and a few other institutions that have a history of not meeting up to civil rights standards. I'm just going to, because there's litigation, I cannot talk about those aspects of things. I'll just say this. I think that the institutions that we support need to make sure that they don't discriminate against Asians, that they don't create situations where Jewish people feel uncomfortable because of just by the fact of their religion, and meet up to high standards like that. And I'm hopeful that there'll be settlements soon enough that'll make a lot of those painful transitions we've had go away.
But how are they to know what you desire them to do if there's no communication?
I mean, the administration is communicating with the presidents of those universities, with the administrations of those universities.
I sometimes hear differing accounts, but let's move on. So you're part of a pretty pugnacious, shall we say, administration, and your boss has called the FDA corrupt and said staffers should pack their bags. He's reportedly called them sock puppets of the industry they regulate. And you yourself have actually written what you call the rot in the medical establishment. So now that you've actually been part of the NIH for a while, how do you feel about your agency now?
Well, I've always loved the NIH on the outside and on the inside. I mean, I wouldn't have accepted to be the head of the NIH if I didn't love it. I got support from the NIH early in my career, which made me into the scientist I am today. I think that the NIH is the crown jewel of biomedical research institutions in the world. So I have not changed my opinion about the NIH one iota in that sense. I do think the NIH needs reform, as you can probably hear from my saying. And I think when we love an institution, we have to be willing to look at its flaws. We have to look at its strengths, try to lift up its strengths, and try to address its flaws.
So I have one more question that I'm going to ask, and before we go to the audience, so I want to give the audience time to think about the questions that you have while we go over our last question, which is that you have had, since you've joined, some dissent in the ranks. A number of staffers at the NIH signed what they called the Great Bethesda Declaration.
They didn't call it the Great One.
Just the Bethesda Declaration? Okay, well, we kind of see where they're going with that, though. But they were saying, among other concerns, that they felt pressured to implement what they called harmful measures and that the agency has become politicized and that cuts are, possibly destroying years of research when the scientists can't complete them. And the letter goes on to say that, quote, ending a $5 million research study when it is 80% complete does not save $1 million, it wastes $4 million. So why do you think they wrote that letter?
I'm going to sit down with them. I've invited them to sit at a round table, find out what they have to say. I'm looking forward to talking with them.
Why do you think they wrote it?
I mean, I'm sure they disagree with some of the priorities that I have.
How do you think you're going to get them all on side and get everybody rowing together at the same time?
Well, I mean, we're scientists. We've never rowed together at the same time.
That's right. We're going to foster a broad discussion of a wide range of ideas.
Yeah, exactly. I'm looking forward to talking to them, finding out. I think, people care about the NIH for a good reason. It's the most important biomedical institution, research institution in the world, by far. People have very strong ideas about how it should be run, what its priorities should be. I've heard many of them, as you can imagine, since I first got nominated. I think I feel the responsibility that very heavily. I want to make sure that the best ideas are reflected in the kind of actions and ideas that I put forward through the NIH. So I find that those kind of conversations really useful. I still have to make decisions and make trade-offs, and I think any leader would say that. But I want to do it in an informed way, and by having conversations with folks like that who also very clearly deeply care about the NIH is how you get to that.
All right, I think we should turn to the audience for questions. I suspect that there are a lot of them. So a couple of points of order. We will have mic runners who will come to you. I'll point to you, and the mic runner will come to you. And also, I would just like to remind everybody that a question has a question mark at the end of it. So please do have a question. I don't know where the mic runners are, though I can get somebody right away. But okay, this gentleman right here, he's right in front of me. And I'll try to go around the room.
I'm very grateful to the NIH for supporting my diabetes research for 30 years. I'm now retired, but I'm curious as to why the Go Mom study, a 5-year study of gestational diabetes at year 4.5, was terminated after 2,700 deliveries.
I don't know the specifics of that study.
It's NIDDK.
Yeah, again, I'd have to look into specifics. Do you know where it was conducted?
It's a multi-center trial. Griff Rogers, I'm sure, can give you all of the details.
Yeah, I mean, you can talk to Griff. A lot of
And the lady in the red jacket there. Yeah, I picked somebody right in the middle that's really hard to get to.
Thank you. Blythe Adamson from Infectious Economics. So as you're aligning the priorities of NIH with an America First agenda, what's your position on collaborations with scientists in other countries?
I think they're really, really important to science, that international collaborations. But we have to do it in a way where I'll just tell you what's motivated me on this, and then I'll tell you the decisions I made about this, right? So I cannot get the lab notebooks from the Wuhan lab, even though the NIH funded the EcoHealth Alliance that had a sub-award relationship with the Wuhan lab. So the NIH funded the work that happened at the Wuhan lab. And I can't get their lab notebook, right? I can't audit them. The sub-award system that we currently have essentially says, look, if I give you a grant and then you give a sub-award to somebody else, you're responsible for auditing that person or that entity. And often, our grantees are not really in a position to do that. Because I believe very firmly that foreign collaborations are really, really important for advancing science, I want those foreign collaborations to continue to happen. We have to go to a system where I can look the American people in the eye and tell them, look, I know where your taxpayer dollars are going. I can actually audit it. I can do the sort of oversight that you would expect. So what we've done is we moved to a new system where the foreign awardee, the sub-awardees, won't be a sub-awardee where the grantee is responsible for auditing. Instead, they will directly draw money from the NIH, and then we'll be able to audit them directly. It's the same way we audit the direct grantee. That way, the foreign collaborations can happen, except on a more firm basis, and I won't have to go in front of Congress and say, well, yeah, we gave money to the Wuhan lab, and no, I don't know what happened there. I'm sorry.
There's so many hands, but I don't know where the mic runner is. Let's try this lady up here. And then we'll go over here.
Hi, Roberta Brinton from the University of Arizona. I want to give a shout out to the National Institute on Aging for their support of discovery, translational, and clinical science, and shepherding that whole process to now a clinical trial to regenerate the Alzheimer's brain. Is that something that you're interested in fostering, that those young investigators that start out young, go into midlife, and then into senior life, that whole development perspective, that whole process?
Absolutely, yes. I mean, I think the basic science that we fund is important for the next generation of cures. And Alzheimer's in particular is a tremendously important problem. I think at latest times, 7 million Americans have something on that order. And there was some friends of mine at USC did a study estimating that like almost like $780 million, $1 billion a year in expenditures in caregiving. It is a tremendously important problem. And we've had a lot of advances in basic science of Alzheimer's disease, but they have not yet translated into treatments that actually address the key problem, which is that we have our grandparents and our parents who can't remember the names of their kids, who can't have their normal activities of daily living, and so we have to solve that. So I'm absolutely committed to that, and thinking and the NIA, that's where I got most of my research support from when I was outside. So I have a fond place in my heart for the NIA. So yeah, I mean, absolutely. I have heard from many researchers, including some old colleagues of mine at Stanford, who have tremendous new ideas, and I'd love to see them tested for Alzheimer's disease specifically. I'm hopeful that we can make advances with that.
We have a question over here.
Thank you so much. First of all, thank you for being here and fielding our questions. I'm a vice chair of research for our department, and one of the issues I have is supporting our young investigators, especially because I'm an anesthesiologist. And unfortunately, or fortunately, our pay is beyond the NIH salary cap. So we have these individuals who are at the cusp of, transitioning into, they're brilliant, they could be researchers, but it's just they're disincentivized to do so because they would be taking such a huge salary cut. And so we don't have a lot of research in anesthesiology. So first of all, how do you intend to support clinical research and clinicians specifically, and then how do you intend to support early stage investigators who are kind of like in that clinical realm?
Yeah, so for clinical research, there's research all across the NIH focused on clinical. There's a whole institute called NCATS that's aimed at this kind of translational science support for clinical work and institutional support for that kind of clinical work. It's a vital part of the NIH portfolio because it's that collaboration with doctors, with caregivers, and scientists working together that often produce the biggest advances that translate over. That problem of like high salary outside is a really tough one, and I don't have an easy answer to that question. Essentially, what we're doing is we're asking people to make a sacrifice, right? So there are programs like the early repayment program. So if suppose you go to medical school and then you develop a lot of debt, as one does in medical school, and then you decide to go into research. If you go into research, the NIH will help pay off your debts. Right? So programs like that help, but the fundamental economics, which is the big difference in salary between what researchers earn and what doctors sometimes earn, that's a real challenge and a real problem. I don't have a clean answer to that.
Fair enough. We had a question down here.
Hi, Leanne Winnick with CBS News. You mentioned medical journals, and your boss, the secretary, has mentioned that he wants to create his own journals and possibly bar NIH research from being published in the traditional journals. So I'm wondering what your view is of that and how that helps, open up more opportunities for more original research and replicated research being published and seen by more people.
Well, the NIH does already have some journals. For instance, the National Journal of the National Cancer Institute is an NIH-funded journal, and so it's not as if NIH has never funded journals before, and the NIH knows how to do it right, I think. I think I'm very interested in having a journal where replication studies, failed research studies can be published. That's a hole in the portfolio of what journals are out there, and something that the NIH can, and I'd love to see the NIH solve. I think that there is space for that. The idea that the NIH supports journals, I don't know why that would be a controversial thing.
In the back, there was a woman who had her hand up. There.
Right here. Hi, my name's Rowan Carvis. I'm from University of Colorado Anschutz Medical Campus, and I'm an early career investigator. I'm going to be applying for the DP2 a couple months from now, which is an early career investigator award. I work in women's health. I'm really hoping that, you were saying today that you plan on expanding early career awards. How exactly are you going to do that? Through the expansion of the DP2, for example, or through maybe some other mechanisms? I'm just very curious how that.
I haven't specifically looked into the mechanisms how to support, but I think that those training awards are an important part of that. Part of it has got to be that we incentivize established scientists who essentially employ postdocs and other students to encourage their advance in their careers. Right, if a late career scientist has a long R01 where they have postdocs that have been around for a decade, that should be part of the evaluation of the success of that grant. Scientists who are good at mentoring other scientists, getting them to getting the young scientists into positions where they can test their own ideas out, like the DP2, and then hopefully a assistant professor job for you. Maybe you already have one. Congratulations. Things like that where we provide incentives, not support, of course, for early career scientists directly, but also incentives for later career scientists and mentorship that we haven't done quite as well as maybe we ought to. Might be ways. I'm really open to ideas for that, and love to chat.
I wanted to get someone on this side of the room as well. There's a hand right there. The striped sweater. It's a little dim from up here. I can't always see everyone.
Thank you so much. My name is Reshma. I'm an early career also investigator at Yale and a primary care physician. I have a question related to reproducibility, and I was very heartened by your remarks related to that. But I was in particular wondering if it's an agency-wide or I guess, department-wide policy, or if it's just NIH specific. And the reason I'm asking this is because we're seeing the opposite happening in some agencies, including a sister agency like the FDA, where they're saying they're going to move away from 2 clinical trials supporting FDA approval of new drugs to 1 clinical trial. And so is that, are you talking about reproducibility in terms of NIH maybe filling up the gap in doing that alternative study to actually show that that clinical trial shows the drug works and is effective? Or, and with the NIH funding cuts that have been proposed, will NIH even have the resources to do that?
I should say, like the FDA has the economics of it are essentially 2 phases in my mind, right? So one is, how much evidence do you require before you approve a product? And then what do you do afterwards to make sure that after the product is now used in ways that you didn't anticipate in the trials, you're looking at and regulating and making sure that the drugs that you proved actually are safe. Where you draw the line on those, and you can see that it's a trade-off, is a difficult, complicated question. It's distinct in my mind from the problem of reproducibility in science per se, right? So which scientific ideas that are out there are true. You need independent people, independent scientists looking at the same idea, looking at it from different angles, finding and seeing if they find the same answer. If they all find the same answer, well, then that idea is more likely to be true than an idea where different teams looking at it find very different things. Primarily the sort of reproducibility agenda that I put forward, I think, is primarily for research organizations that focus on supporting scientific things, scientific agendas and scientific projects. How you regulate drugs, that's a different question about where how much evidence do you require before you say, yes, this drug is safe enough to let everyone take it, and then how aggressively do you look at it after the drug is been put out? There's a tremendous literature on this. I actually contributed once to some of these questions.
Just to follow up, would it be fair to say that when you're talking about replication, you're talking about maybe more like basic science as opposed to a clinical trial that takes 10,000 patients and takes 10 years to complete?
Obviously there's some economics there as well, right? So when you're talking about large trials, there's only a limited number of sort of pulls at the slot machine you can do in some sense. So you have to be very careful about that and choose very carefully how you do it. I think that if you're going to do science that matters for people, especially those results that matter most, you kind of want to invest in that kind of replication. You can be certain. I just think about like the fact that in 1968, the American people were told that eggs were bad for you, that eating them they have high cholesterol, and eating them was going to cause heart attacks. And then later they're told. I know this because I was traumatized by not eating eggs in my youth. Okay, you can eat the whites, and it's a sad existence where you only eat the whites and not the eggs, the yolks, and now they're a superfood. I think the key thing is. It's not that the science doesn't evolve. There's no problem with that. The fact that some scientific result is wrong is commonplace. It's how much confidence can we have when we give advice to all of the American people that this is the right thing to do. There, I would love to see that advice be based on replicated science, where we're really certain that it's right. And when there's something that's out there as an interesting hypothesis, but hasn't been subject to that kind of replication, we're a little more humble, if you will, in talking to American people about it. That's the way I think we rebuild trust.
I think we have time for maybe one more question. There's a hand right here that's kind of waving its fingers, and there we go.
Thank you so much for being here today. You're the main reason I'm here. My name is Joni Clark. I'm from Aspen, Colorado, and I worked with John Denver's WinStar organization that started a lot of these good ideas in education for children. And then we started the alternative medicine in this valley and sent everything we did to Congress. Then I worked with Professor Colin Campbell of Cornell, the #1 nutritionist in the world, on the China study and forks over knives.
Do you have a question for Dr. Bhattacharya? We have very little time left with him.
Anyway, given all of that, I am so grateful that you're going to focus on nutrition. Socrates was right. Food is our medicine. So thank you. And all that we have done, I want to offer to you guys.
Okay, actually, there's a gentleman right here. Let's get one more question in. We have time.
Thank you so much for that. We're absolutely going to focus on nutrition. We need better advice for folks on it, better science.
Quick question. Help me understand. You said as rationale for cutting research at NIH is that life expectancy has...
I didn't say that as a rationale for cutting it.
It's kind of sounded like it. That's what I heard.
Well, you heard it incorrectly. I didn't say that.
We haven't made any progress in life expectancy. What I'm trying to understand is...
I didn't say that. Just so we're clear, I did not say that.
Well, that's what I heard. So anyway, what I really is how
that's
do I
not what I said.
reconcile
But
that
so you know,
with the fact that cancer mortality has been steadily declining over the last few decades for lots of reasons, including research at NIH.
I mean,
you can't answer the question. So
I'm not sure if there was a question in there.
I didn't hear.
Yes, let's try one more. Let's get it. I hope you remember the question mark.
I'm sorry. You're just misrepresenting what I said. I didn't say that.
Hi, I'm Seema Kumar. I'm CEO of CURE. It's an innovation campus in New York City. And I worked at NIH before, a long time ago, and love the institution. So one question that I have is, what is the role of private sector? And what do you see as an important part of, the alter ego to the basic science, if you will? Because ultimately, that's what impacts the health of American people, right? So public-private partnerships, the role of public sector and private sector.
No, I think the private sector is tremendously important. The NIH, in a way, it solves a market failure, right? It's supposed to support research that the private sector wouldn't normally do. Right, where there's an idea that has, in the language of economics, positive externalities that are not, patentable in some ways. I mean, that's the primary mission of the NIH. The role of the private sector is to take those ideas and expand them, make them affordable, available to everybody, so they're useful. I think that the collaboration between the NIH, the public mission, and the private sector is longstanding and deep and needs to continue if the ideas that we support really will make the leap and make America healthy.
Well, I'm afraid we're going to have to leave it there. We went a little over, and we may never get invited back if we go too long. Thank you so much for all of your time. I think the audience enjoyed it. Thank you very much.